collaborative organization committed to enhancing stroke prevention as well as care for all people in Ontario. And the network is the credible advisor really to the whole Ontario stroke system and leads provincial, regional, and even local initiatives and programs. The vision of the Ontario stroke system is basically to simply have fewer strokes, and of the people that do have strokes, make sure they have better outcomes. And hopefully these guidelines that you're going to listen to today will be kind of part of some of those best practices about people having better outcomes after stroke. So again, we're here to talk to you today about the recently released guidelines for community-based exercise programs for people with stroke. Stroke is the third leading cause of death and long-term adult disability in Canada. Each year, more than 50,000 Canadians experience a stroke, and over 14,000 of those people actually die as a result. What is particularly relevant for this presentation and the context of this presentation is that there are about 300,000 Canadians living with the effects of stroke. And of those, about 65% are left with some type of disability. These survivors often struggle to access conventional community fitness programs because of their ongoing physical and cognitive deficits. Yet there's very good and strong evidence that they would benefit from regular exercise. These guidelines were developed to assist community exercise providers to design and deliver safe and effective programs that meet the needs of people with stroke in a variety of community settings. In order that stroke survivors maintain the gains achieved while in hospital, as well as to continue to recover, community exercise programs need to be available for them. The guidelines are intended as a framework to help guide community-based providers to deliver programs that meet the needs of the stroke survivor, as well as to help people living with stroke in the community and their healthcare providers to evaluate and probably identify exercise opportunities in their very own communities. In terms of the background of where this initiative came from, community engagement forums in 3 stroke regions across the province were completed over the last few years. And in these forums, we engaged stroke survivors, their caregivers, as well as community service providers. And we wanted them to really identify gaps in the system preventing people with stroke to live fully in their communities. The picture on this slide is really an example of some of the work done in those forums. A return to the community is really the initial part of the whole recovery process. As you know, probably hospital stay is really only a short chapter in the whole person's journey with stroke. And so stroke survivors seek to engage opportunities to be active that support their continuing recovery, enable them to regain their independence and interact with people affected by stroke, as well as the broader community. People with stroke caregivers and community service providers highlighted the need for community-based exercise programs that really meet their needs. In response to this, in the need for instructors providing these community-based exercise programs to be aware of the multifactorial nature of stroke and for them to have the appropriate training to support this programming, a provincial panel of experts in the fields of stroke rehab and community exercise programming drafted these guidelines. The expert panel met for the first time approximately 2 years ago, and members participated in monthly teleconferences and smaller working groups working between meetings to develop these guidelines. That's a little background. So as you can see from this slide, the guideline working group had a broad representation from across the province of Ontario and included representation from the Ontario Stroke Network, as well as stroke rehabilitation therapists and community exercise providers. As you have heard in previous slides, stroke survivors want opportunities to participate in exercise programs to continue their recovery. However, research also supports this need and for these opportunities. For example, the 2011 Canadian Physical Activity Guidelines recommends that all adults engage in approximately 150 minutes of vigorous activity per week. The 2010 Canadian Best Practice Recommendations for Stroke Care recommend that stroke survivors be provided with a cardiovascular fitness program to maximize their functional outcomes after stroke as a part of overall vascular risk reduction, and they should be prescribed modified activities to allow age-appropriate target heart rates to be achieved. However, despite these recommendations and research, there is very limited capacity among exercise providers to offer programs that adequately respond to the specific needs of stroke survivors, which particularly impacts those living in the community with mild and moderate deficits, and they may benefit from these programs. These guidelines may help to translate research and best practice recommendations into sustainable community programs. That is really our hope. So the intent of the guidelines is to build capacity in the community to support stroke survivors in their recovery, provide guiding principles for safe exercise for stroke survivors. We want them to be based on best practice and the most recent available research, built on the expertise from previous evaluated and successful community exercise programs with stroke survivors. As well, it was our intent that the guidelines would also act as a resource kit that links providers to resources and research to help assist them in the development of programs or with the integration of people with stroke into already existing programs. Also, we have developed a brochure that goes along with those guidelines to assist stroke survivors and caregivers to help them choose programs that might meet their needs. So with that background, I'll pass you on to Alda, who will review the first 6 guidelines.
Thank you, Paula. I will discuss guidelines 1 to 6, as Paula just mentioned. The first guideline is medical clearance. It is recommended that community programs incorporate a medical screening process completed by a physician or a nurse practitioner to ensure that there are no contraindications to exercise for the individual. A screening process ensures safety of participants in the program, as well as ensures that due diligence has been done on the part of the exercise provider. Here we go. We felt it was important to include a guideline to address medical screening, as people with stroke fall into a higher risk category with respect to exercise. They often have other comorbidities, such as high blood pressure, diabetes, and arthritis, which need to be considered. They may also be elderly. The screening process has 2 components. It should include information to the physician or nurse practitioner about the exercise program itself, such as duration, type of exercise, and intensity. And the exercise provider should receive from the physician or nurse any pertinent information, such as contraindications, and obtain clearance for participation prior to the start of the program. It's important to know if the individual has any uncontrolled conditions, such as atrial fibrillation, or if they use medications that may impact on exercise, such as beta blockers. A lot of the research and literature has participants undergoing stress tests prior to the beginning of a program. We were aware that this may not be feasible across the province in terms of access or timeliness, and didn't want this to be a barrier. Some literature indicates that a stress test is required if cardiovascular and aerobic exercise is the main focus of the class. If this is not available, then it's recommended that the individual work at a more moderate level and increase the duration of exercise to compensate for a lower intensity. To ensure that the guidelines are user-friendly, several links to additional resources are included in the document. There are links to various screening forms that are used in the community across the province and elsewhere in the country, such as the PARMEDX, as well as forms that are used with the SANE, Keep Moving with Stroke, and Time Exercise programs. The second guideline speaks to more of a functional screen completed by the exercise provider in order to ensure a good match between the program and the participant. The screening process should include an intake interview. Does the individual meet the inclusion-exclusion criteria of the program? Review of health information, a functional ability assessment that includes measures such as the bird balance test, kind up and go, 2-minute walk, and gait speed. This will provide an indication of their ability to participate in the class with respect to balance and mobility, and the amount of supervision they require. The functional screen may be completed by a fitness instructor, kinesiologist, or the healthcare link between a rehabilitation program and the community. Often this is a physiotherapist. Why is the functional screen important? Stroke survivors present with a wide degree of abilities, and exercise providers should be aware of any limitations in order to ensure that the program is a good match for the individual. Some people may have needs that are beyond the provider's capacity to accommodate in a particular program. And for this reason, programs, inclusion criteria, and linkages with more specialized programs for healthcare providers are also suggested. Some examples of inclusion and exclusion criteria are ability to follow directions, ability to self-monitor, and walking tolerance. Such criteria help to determine the degree of support an individual needs to safely participate in a program. It should be mentioned that some of the criteria may be waived at the discretion of the exercise provider if adequate support and supervision is available. Several resources are included to support this guideline. Sample intake questions covering 13 domains, such as mobility, communication, and cognition are provided. For mobility, you would want to inquire about walking ability. Does the individual need assistance or supervision, or do they walk independently? Is a walking aid or other assistive device, such as an ankle cord or sofa, needed? For communication, sometimes a stroke can affect the person's ability to communicate. It's important to know if they have an aphasia. If so, are there supportive communication strategies that can be used to promote effective communication between the instructor and the participant? In terms of cognition, it's important to know if the individual is able to follow directions. Can they correctly self-monitor in terms of pain or exertion? Do they know their limitations so that they are not taking risks when they exercise? Guideline number 3 addresses class structure and supervision. Every program will be different based on the participants, the resources available, and the class format, whether it's a seated class or whether it's a balance and mobility class, for example. The duration of the program varies as well. In the literature, programs are anywhere from 4 to 16 weeks. It's important to consider what you can provide, the needs of the individual, and what the facility can reasonably offer. Some factors that should be considered are the knowledge and ability of the exercise provider. Do they have an understanding of stroke, the impairments it may cause, and the impact those impairments have on exercise? Is assistance available? Other than additional staff, volunteers, students, inclusion workers, or caregivers may be used to provide assistance. The abilities of the participants and the amount of assistance they require should also be considered. Also, participants, staff, and volunteers may have education needs that would need to be addressed prior to the start of the program. In terms of rationale for this guideline, the instructor-participant ratio is important to include as it speaks to safety for participants and provides guidance on the use of volunteers or family members to meet an individual's needs. The class ratio depends on the program. In the literature, the range varies from 1 to 3 to 1 to 5, with a class size of 12 to 15. Class size will also depend on what the facility can reasonably offer. For example, a program may have a 1 to 4 ratio with 1 paid instructor, 2 volunteers for 12 participants. As a resource, there are links to the literature addressing class ratio and to the Canadian Fitness Safety Standards, which many of you are familiar with. These standards also provide recommendations around participant numbers. The fourth guideline addresses the format of the exercise class. It's recommended that established training principles and stroke-specific components such as aerobics, strengthening, stretching, balance, and coordination be integrated into the class. These components address the needs of people living with the effects of stroke and support them in achieving maximal independence and mobility. Programs should follow the fifth principle of frequency, intensity, time, and type. Exercise specificity and progression should be considered. To use the step-up exercise as an example, and it's there on the bottom left-hand side of the screen, this is an exercise that specifically addresses leg strength, which can, in turn, can improve the person's ability to climb stairs. So it's a functional strengthening exercise that increases community mobility as well. In terms of progression, you could begin without a riser on the steps, then gradually add additional risers to increase the height, or you could begin using 2 hands for support and then gradually decrease the amount of support that's available. Exercises should be modified to suit the ability of the participant as well as meet their needs. In terms of resources, there are links to the Board Grade of Perceived Exertion and the TALK test, which are both ways participants can determine the intensity at which they're working. There are links to several established community exercise programs for people with stroke that are provided as examples. And as well, there's a table from the literature outlining exercise principles specific to stroke, and this can also be found in the document. Program evaluation is an important concept of program delivery, not only for measuring participant satisfaction, but also safety and health outcomes. There are a number of measures that can be used, and which measures to use may be determined on where the program is taking place, what partners are involved, or outcomes required related to the funding requirements. To support guideline number 5, several evaluation components are suggested. Process indicators could include the number of new and returning participants, attendance, number of adverse events, near misses, and the number of people on a wait list. Outcome indicators could include participant satisfaction, which can be measured through questionnaires, testimonials, or re-registration rates, the number of participants moving on to mainstream exercise or recreation activities, and we recognize that for some participants, this transition may not be possible, and success can be measured through ongoing participation in adapted programs, as well as integrating exercise into daily life. The number of participants engaged in regular exercise, and the participants' self-reported functional gains are other examples of outcome indicators. The 6th guideline addresses specific training for fitness instructors. In the community setting, this can be one of the biggest challenges for health professionals. Health professionals will tell individuals to exercise on their own, however, they may feel uncomfortable referring to specific community programs. Working with community providers can help to overcome this challenge and ensure individuals have the opportunity to exercise in their community. Working with stroke survivors not only requires stroke-specific training, but ensuring individuals have the skills required for effective program delivery. People with stroke may present with functional impairments that require advanced skill sets to decrease exercise risk factors and to safely adapt programs. In order to provide safe and effective programs, instructors need to be aware of the multifactorial nature of stroke. Training programs available to fitness instructors who are leading programs for people with stroke should cover the following competencies: understanding of issues specific to stroke, such as the pathology and presentation, physical and cognitive impairments, and the effect of medication on exercise are examples. Other competencies include ability to make judgments as to whether a participant should be excluded from a program or when to refer to their physician. Ability to progress exercises safely to avoid falls, avoid excessive muscle soreness or fatigue and cardiovascular stress, and the ability to train and direct assistants, volunteers, and caregivers. Several resources and links are provided for further information. These include Canadian Fitness Safety Standards, contact information for local district and regional stroke centers, and various training programs and resources such as the Post-Rehab Exercise for Stroke program, a self-study DVD resource, and the Fame and Time exercise program. At this point, I'll pass you back to Paula, who will review the remaining guidelines.
It's Janice's machine we're in.
Thank you, Alda. So I'm going to review the last 2 exercise guidelines. So in terms of guideline number 7 regarding the facility, when delivering community-based program, it's extremely important that the environment obviously be considered to ensure that that the participant has a safe and positive experience. Participants should be provided a tour of the building to ensure they are comfortable with where to go, as well as ensuring that the facility is easily accessible and really barrier-free.
You done, Donna?
Safety is a primary concern. Oops, I'm wondering if I'm kind of off here. Sorry, everybody, I'm just going to the right slide. Okay, around guideline number 8, the emergency plan and equipment, safety is a primary concern when determining where a program should take place and who is delivering it. In an emergency situation does occur, you want everyone to know exactly what to do and who is responsible for what. Having a documented plan individuals that know CPR and first aid, easy access to a phone, and a source of glucose, for example, for people with diabetes, is highly recommended.
They sounded like they were on drugs before.
Providing a facility that is barrier-free encourages safe participation by people with stroke who are experiencing a variety of degrees of limitations. This includes ensuring that the training environment is wheelchair accessible with adequate space to permit transfer to and from equipment. The program provider, in collaboration with the participant and their support, should also identify any ongoing transportation needs that the person with stroke may have in order to attend the program. It is the experience of many programs provided to stroke survivors that even though they indicate that they want exercise providers available to them in their community, at times, even when offered, they are still not able to access them due to barriers such as transportation. As well, consideration should also be given to the temperature of the exercise room to safeguard against overheating or dehydration. The temperature should be kept constant, and participants should be encouraged to bring bottles of water to drink. As well, the exercise provider should be prepared to respond to any emergency situation in support of a safe environment, which includes the Canadian Fitness Safety Standards, as well as in-house personnel trained in first aid, as I said before, and the presence of an AED is highly recommended. There are numbers of standards and resources that are built into the guidelines for number 7 and 8, and obviously they include links to barrier-free design. The Ontario-built environmental standards are expected actually to be released in 2011 and will provide barrier-free design standards. And again, that gets mentioned before, it does include the Canadian fitness standards as well. So really, the guidelines really were intended to provide the reader resources and tools with which to use to help make designing programs or integrating stroke survivors into those programs much more easy. These guidelines have gone through external review by a panel of academic experts, stroke researchers, and community fitness instructors. These experts reviewed the document for content, format, gaps, and even the feasibility of these guidelines. They've been also endorsed by the Ontario Stroke System. As discussed, the document contains detailed rationale for each guideline, as well as resources, tools, and references that will be useful for exercise program providers and healthcare professionals. A companion document entitled Choosing a Community Exercise Program, a guide for stroke survivors, has also been developed to provide stroke survivors and their families information on how to choose an appropriate exercise program in their community. So the hope is that they will have these pamphlets available in communities through district stroke centers, for example, and outpatient therapy departments, that sort of thing, that they could give to stroke survivors in order to kind of help them make those decisions about what community-based exercise programs would be best for them. Regarding next steps, the initial working group members, such as ourselves, are presently disseminating the guidelines through conference presentations, webinar presentations such as this one, video conference presentations, and poster presentations at conferences. The guidelines for community-based exercise programs for people with stroke are not yet available, but will be available electronically and can be downloaded for free on the new Ontario Stroke Network website. So you'll see that website address on the screen. So again, they aren't yet on that website, but hopefully in the next few weeks they will be available. And my hope, too, is that we could have Dana forward the PDF of the guidelines to the participants today, or to the mailing list from your mailing list, Dana, in order to kind of get them out. But again, you can also contact any of the presenters today to get a copy of the guidelines when available. And again, they're just kind of with the graphic designer, making them look pretty, and hopefully they're available in the very near future. As well, the stroke survivor brochure and a flyer promoting the guidelines among exercise providers will be able to be found on the same website. And our plan for these guidelines is to have them reviewed and updated every 2 years based on best practices that are coming out. So with that, I will conclude our presentation today. I'd like to thank you so much for your interest in the guidelines and listening to our presentation. This slide has our contact information, and please feel free to contact us after if you have any questions past today's presentation, but we have lots of time for questions if there are any.
So we'll just make sure that your lock talk is off, Paula. I think it is because I'm not hearing any feedback. And when we move into the question portion of our webinar, what I'd like to do is make sure that you use the hand raise button if you want to verbally ask questions. So if you are going to verbally ask questions, in order to talk so that we can hear you in the classroom, you need to use the control key to hold down the talk button. And when you use the control key to talk, make sure you hold it down the whole time that you're talking. You can also use your mouse and hover over the talk button and left click on your mouse and make sure you hold it down while you're talking, but that will hold down the talk button as well. And then when you're done talking, just take your finger off the control key or your mouse button so that somebody else can talk and we don't get feedback. Another option, if you're shy and you don't want to ask your questions verbally, is that you can type them into the chat area. Just make sure that you type the question to the whole room so we can all see the question, and then we can answer your question as required. So I see that we have a question from Donna. Donna, if you'd like to ask your question verbally, I'm going to take my finger off the talk button now so you can go ahead. And Donna, when you ask your question, just make sure you hold down the control key while you're asking the question.
I don't know if you can, but you might have to hear the question.
So Donna might be having some technical difficulties. Donna, if you'd like to type your question into the chat area, you can do that as well. Just type it into the little box beside to the room, and then it'll show up in the chat area when you press enter. And if anybody on the phone has a question, we've got quite a few people logged in on the phone, so we can try and go through those questions, but unfortunately you're just going to have to ask your question and hope we don't have a pile of people talking on top of each other, because we don't have the option of using the hand raise button when you're logged in on the phone. So anybody on the phone can ask a question.
Hello?
Yep, we can hear you. Did you have a question?
I see Donna has typed a question in the box, and so just in case everyone can't see that, Donna's question is, what is the ratio and type of composition of staff to clients for an exercise class or a pool class? And again, Donna, I think that ratio really depends on the skills and abilities of the people that you have participating in the class. So hence the importance of kind of having that screening done by the exercise provider. But in terms of the research out there, the literature, there is a varied range, but generally it's kind of one instructor to every 3 participants, from as low as that to as high as kind of one instructor to 5 participants. And the class size kind of ranges from 12 to 15. But I guess there is multiple variables that kind of fall within that, unfortunately, in terms of having kind of a clear-cut answer. Alda or Genevieve, would you like to add to that?
Sure, this is Genevieve from the YMCA. I can comment from our perspective, from a community perspective, and I believe Paula's comment is really valid. It depends on the group that you're working with. The YMCA has partnered with Hamilton Health Sciences and at McMaster University for a randomized control study for stroke participants, and we're looking at a ratio of 1 to 4. Having said that, we're also including volunteers, and some of them are kinesiology students, some are physiotherapy students, as well as
some members and stroke survivors that are included in our ratios to help out in managing the program delivery.
And so, Genevieve, I'm wondering if you two could maybe just elaborate on that, because I see there's another question from Ashley that says, how do you utilize your volunteer help and what is their role?
This is Genevieve again. I can comment on how we're using volunteers in our program. Volunteers are utilized, I think, in a lot of great capacities, whether they're student volunteers, previous stroke survivors, and more members that are interested in working with this population. We have volunteers that are working to help facilitate an educational component of the Living with Stroke material, as well as working hands-on in the program to assist the instructors with the exercise program.
Thank you, Genevieve. Are there any other questions? Or Donna and Ashley, did we answer the questions adequately?
So if there are no more questions, we will be sure to have the contact information slide. Oh, we've got another one, Donna. Donna, I'm not sure if you wanted to speak verbally or type your question into the chat area, but whatever you'd like to do, go ahead.
Okay, I see Donna's typed her question into the main chat room, I believe. And the question is, do you have guidelines on vital signs for these clients? And Alda, I'm going to turn that question over to you.
Okay, thanks, Paula. With respect to, from an intensity point of view, it's recommended that if you're using a board scale of perceived exertion, which is a 10-point scale, you would ask the individual to ensure that they're exercising at a level of 3 to 4, which is moderate or somewhat hard, with 0 being nothing at all and 10 being the maximum. Other measures you can use are the talk test. So in that capacity, the individual will work to the at the level in which they can still carry on a conversation without becoming breathless. Anything more specific related to their individual condition, you hopefully receive that information from the physician.
I can comment as well from the YMCA. For our group exercise sessions, people involved in our program, we have created, it's not specifically in the guidelines, but it's one of the things that we do for specific measures is before every exercise session, we have an exercise safety sheet where we will check with people to see if anything has changed. We will do blood pressure checks to make sure that it's within proper exercise guidelines, which you know, are kind of common practice out there. So it's just a chance to touch base. We don't do any diagnosis or anything in the case of that, but it's a chance for us to see if anything has changed and make sure that people are safe to actually exercise for that particular day. And then if there's any questions or concerns on that, we would send them back to their physician.
Are there any more questions? I've put up the contact information slide for Genevieve, Alda, and Paula. So if you think of any questions after you have a chance for this information to soak in, then you can send them an email directly. Excuse me. Or you can also send me an email at dana.vangorp@uwo.ca. and I can forward the email to the appropriate person. I want to thank Genevieve, Alda, and Paula for coming into the virtual classroom today and sharing their information with us. It was an excellent presentation. And we do have another webinar coming up on March the 28th, I believe. That's a Monday at 1 o'clock, and that webinar is exercise prescription for arthritis, and we have a presenter from the Arthritis Society coming in to speak about that. So I'm going to close here if Paula, Genevieve, or Alda doesn't have anything else to add, and we will hopefully see you all back in the WIMBA classroom in March. Thanks a lot, everybody. Paula, do you see that Jeanette has a question there? She's just used the hand raise button. Jeanette, you can ask your question verbally using the talk button, or you can also, type it into the chat area.
Jeanette, do you have a question?